See, today's topic is insulin along with oral hypoglycemic agents. So, okay, when it comes to the pharmacology point of view, majorly we need to focus classification, mechanism of action, specific use and drug of choice along with adverse effect and antidote, followed by drug interaction. Next, see what is the difference between disease and disorder. See, disease that is caused by the microorganism. Disease is caused by microorganism. Disorder is majorly due to the imbalance between the two systems. If imbalance between sympathetic and parasympathetic nervous system, then we people will get hypertension. Okay, decreased GABA level, increased glutamate leads to the epilepsy. So these are the epilepsy is a disorder, hypertension is a disorder. So like that, this diabetes also disorder. So what kind of imbalance we need to observe in the next slide. Okay, see when it comes to the normal physiology, storage of glucose. See normally excess glucose can be converted into glycogen. So that glycogen can be stored in the liver. First it is stored in the liver. If liver is get saturated, then glycogen that can be stored into the muscle. That is the second place. If muscle is get filled or muscle is get saturated, then it can be stored into the adipose tissue. That is third place. So like that in the liver, followed by muscle, followed by adipose tissue. When it comes to the physiology of cholesterol storage, excess cholesterol that can be stored in the liver and majorly in the adipose tissue. So cholesterol that can be stored in the liver along with adipose tissue in the form of triglycerides. See if all this liver, okay, muscle and adipose tissues get filled or saturated, then that whatever that excess glucose is there, that can be retained into the in the blood vessel, so it may lead to the diabetes mellitus. So when it comes to the metabolic pathways, okay, when it comes to the metabolic pathways, that is from biochemistry point of view. See here, see glycolysis. Glycolysis is nothing but conversion of glucose into the 2-pyruvate or lactate plus 2 ATP molecules can be synthesized to NADH along with water molecule. So this takes place in the glycolysis, it will takes place in the cytoplasm. Next comes to the glycogenolysis. See glycogen synthesis means glucose that can be converted into glycogen. Okay, whatever this glycogen is there, that can be stored into the liver. We have discussed in the liver, followed by muscle, followed by adipose tissue. Next comes to the glycogenolysis. Whatever that formed glycogen that can be converted into glucose. Okay, that is takes place in the cytoplasm. Okay, this can be stimulated by glucagon and epinephrine. But this glycogen storage that can be stimulated by insulin. Next, glucogenesis. Glucogenesis is nothing but generation or synthesis of glucose from the non-carbohydrate source. So what are these non-carbohydrate source? Nothing but amino acids, lipids, glycerol, pyruvate leads to the synthesis of glucose. So this is about a brief information about the metabolic pathways. Next comes to the diabetes mellitus. See diabetes mellitus, what is the definition of diabetes mellitus? Nothing but consistently elevated blood glucose level, we can call as a consistently elevated blood glucose level, we can call as a diabetes mellitus. See, first we have, after taking the food, what will happen is increased glucose level in the blood. Okay, after some time what will happen, slowly the glucose level can be reduced. See, there is a normal fluctuation will be there, normal fluctuation among the glucose amount. See, concentration of glucose in the blood. So this is a normal fluctuation will be there. But at what case we can call as a diabetes mellitus? Nothing but consistently for more number of days, whether it is 3 months or 6 months, up to 3 months or 6 months, there is a continuous elevation of blood glucose level. That condition only we can call as a diabetes mellitus. Next comes to the blood sugar level. So what condition we people can call as a diabetic condition means see, fasting plasma glucose. Fasting plasma nothing but before taking the food. Okay, before taking the food, the normal blood glucose is 70 to 100 mg per deciliter. Okay, if it is 100 to 126 mg per deciliter, then we can consider as a pre-diabetic, means about to diabetic. Next, if it is greater than 126 mg per deciliter, then that condition we can call as a diabetic patient. Next, postprandial means after taking of the food, the glucose limit, that is 180 mg per deciliter. Okay, that is the normal condition. If it is 180 to 200 mg per deciliter, then we can call it a pre-diabetic condition. If it is greater than 200 mg, then we can consider as a diabetic condition. So simply diabetic nothing but fasting plasma glucose level is greater than 126 mg per deciliter. When it comes to the postprandial glucose level, greater than 200 mg per deciliter. Okay, HbA1c nothing but hemoglobin estimation, means how much amount of glucose that can be bound to the hemoglobin. That is, if it is less than 6%, means this is a test, the test by which we can determine whether it is a diabetic or non-diabetic patient. Means by this test is there. If the percentage is less than 6%, then it is normal. If it is 6 to 6.5, then it is pre-diabetic condition. If the percentage of HbA1c is greater than 6.5, then only we can call as diabetic condition. So diabetes are two types. One is type 1, another one is type 2. When it comes to the type 1, it is a insulin dependent. Okay, so what will happen means 90% of beta cells not functioning properly. So what will happen, ultimately no insulin can be synthesized. So insulin therapy is needed. See, if no insulin is there, see here beta cells are lost, means 90 beta cells are get damaged. If beta cells are damaged, no synthesis of insulin. So what we people need to give means only insulin therapy is needed in case of type 1 diabetes. When it comes to the type 2 diabetes, it is non-insulin dependent. Okay, no beta cell loss. See, beta cells are no loss of beta cells. Here oral hypoglycemic drugs are needed. Oral hypoglycemic drugs are there. So drugs can be given in case of type 2 diabetes. Insulin therapy means supplement of insulin, okay, by subcutaneous route or any other route, that can be useful in case of type 1 diabetes. So here type 1 nothing but first source, that is pancreas, is getting failed. Okay, 2 nothing but see, type 1 pancreas is the first that will releases the insulin. Second one is the cell, insulin acting part. See, type 1, that is the first pancreas is get failed. In type 2, the cell is get failed. Pancreas is failed to secrete the insulin, that is type 1. Okay, cells fail to take the glucose, that is a type 2 condition. See, this is a pancreas, okay, that will not produce the insulin into the blood vessels. Then what will happen, no insulin can be entered into the cells. So this is the type 1 condition. When it comes to the type 2 condition, see, the pancreas is in good condition. Okay, it will synthesizes the Okay, it will synthesize as the glucose molecule. Okay, it will produce as the glucose molecule, but the thing whatever the synthesized glucose molecule, that may not be entered into the cell, because cell has the resistance. This indicates resistance. Cell has the resistance to enter the glucose. Then what will happen again, the glucose can be retained in the blood vessel only. So resistance produced by the cell, hence what will happen, glucose may not be entered into the cells. So that's why, so in type 1 condition we need to give the insulin, because insulin is not at all secreted. Insulin we need to give. In case of type 2, what we need to do, we need to sensitize the cells, we need to activate the cells. Okay, sensitization of cells. In type 2 we need to sensitize the cells, so the glucose might be entered into the cells. Next, hemoglobin A1C, that's why you can call it HbA1c. See, HbA1c is a minor component of hemoglobin to which glucose can be bound. See, the HbA1c value is 6.5 or more than 6.5, then it is confirmed as a diabetic condition. Next, HbA1c levels are measured to monitor the blood glucose level fluctuation in case of diabetic patients. Okay. Next, in case of pregnancy and uncommon form of hemoglobin, then we we can use a random blood sugar test or a fasting blood sugar test. In case of pregnancy and in case of uncommon form of hemoglobin, then we can go for random blood sugar test. So this is, they have asked in the GPAT 2015 and 2011. See, diabetes, very important. Diabetes, it is a metabolic disorder. Okay, the main reason, okay, if diabetes further it may lead to the chronic conditions like congestive heart failure, stroke, kidney damage, eye damage, finally leads to the death. See, because in case of diabetes, if it is untreated, it may lead to the congestive heart failure, stroke, kidney damage, eye damage, it may lead to the death. So that much complications it can be produced. So this is the insulin. Okay, this is the structure of insulin. It is containing A chain and B chain. Okay, all these are the amino acids, these are the disulfide bonds. These are the disulfide bonds. Here, human insulin that containing 8th amino acid is threonine. Okay, A9 is serine, A10 is isoleucine. Okay, in the B chain, 30th amino acid in B chain is threonine. In case of porcine, okay, the 8 is threonine, 9 is serine, isoleucine. Okay, but in the B chain it is get modified, that is alanine will be there. Next, in case of bovine, see, A chain alanine is there, A8 amino acid, A9 is constant, A10 in the A chain 10th amino acid is valine. Next, in the B chain 30th amino acid is alanine. So in case of sheep, A8 amino acid is alanine, A9 is glycine, A10 is valine. Okay, B30 is alanine. So this is just what is the structural difference or amino acid difference that can be present between human, porcine, bovine and sheep insulins. See, insulin, initially it can be synthesized as a pre-pro-insulin that is containing 110 amino acids. Okay, next that can be synthesized into pro-insulin, okay, that contains 86 amino acids. Finally it is insulin can be produced. The A chain that is containing 21 amino acids. Okay, B chain that is containing 30 amino acids. Okay, so next one is this is the regulation of insulin secretion. See, if GAT tract that contains protein or carbohydrates or fat, protein that can be converted into amino acid, carbohydrate that can be converted into monosaccharides, fat that can be converted into fatty acids. So all this will stimulate the pancreatic beta cells. Then what will happen? Insulin release can be takes place, or GAT hormones. GAT hormone that will activate beta cells, thereby secretion of insulin will be there. Okay, alpha 2 activation of alpha 2 receptor by sympathetic nervous system that will inhibit the release of insulin. Next, parasympathetic nervous system, that is by vagus nerve, it will also stimulate beta cells to release the insulin. So this is the regulation of insulin secretion. See, whenever there is a hypoglycemia, the counter regulatory sympathetic stimulation tends to raise the blood glucose to the normal level. See, in case if blood sugar level is get reduced, then what will happen? Sympathetic system is get activated in our body, so thereby increases the blood glucose level. So normal blood glucose level during the fasting condition, that is 6.1 to 7 millimole per liter, or 110 to 126 mg per deciliter. So this is a normal blood sugar level. Okay, see, hypoglycemic hormone, if release of insulin hormone, so what will happen? Reduced blood glucose level. Okay, increased release of hyperglycemic hormones, growth hormone, thyroxine, okay, glucagon, corticosteroids and catecholamines. So all these hormones responsible for the increased level of glucose. Insulin is responsible for the reduced level of glucose. So because of this imbalance, we people will get the diabetes. See, next one is mechanism of action of insulin. See, insulin that can inhibit the gluconeogenesis. Already we have discussed the definition. It also inhibit the hepatic glycogenolysis. Okay, but it may not do any kind of action on elementary absorption of glucose. By inhibiting this glycogenolysis and gluconeogenesis, what will happen? It will reduces the blood sugar level. Along with that, it will stimulate the peripheral utilization of glucose. Okay, stimulates the lipogenesis, stimulates the protein synthesis. Okay, these are the actions of insulin. Along with that, see how the insulin that will act on the cell means, see the cell that contains cell membrane. Okay, next one is insulin receptor is there. Insulin receptor, it contains 2 alpha subunits, 2 beta subunits. 2 alpha subunits, these are present, okay, outside, these are the present located outside the cell membrane, but beta subunits are transmembrane. These are the transmembrane. Along with it contains tyrosine moiety. Beta subunit, it contains tyrosine moiety. Okay, whenever the insulin that will come and bound to this alpha receptor, this alpha subunit, what will happen? There is a activation of beta subunits will be there. Once the beta subunits are get activated, then what will happen means the phosphorylation of tyrosine moiety. The tyrosine moiety of beta subunits can be get phosphorylated. Okay, because of this phosphorylation and dephosphorylation, because of this phosphorylation and dephosphorylation, what will happen? The entry of glucose will takes place in the cell. So this is the mechanism of action. Next comes to the sources of insulin. See, insulin was initially extracted from the animal sources, okay, until advances in the technology enabled the production of biosynthetic human sequence, that is biosynthetic human sequence insulin. Insulin analogs are synthetically produced. Okay, insulin analogs are there, those can be synthetically produced, but initially we have extracted the insulin from the animal sources. See, first animal insulin from the bovine or porcine, next human insulin by biosynthetic pathway, followed by insulin analog synthetic pathway. Okay, see, insulin preparations. Insulin which are obtained from the pig and beef, it contains pancreatic protein and proinsulin. So it contains pancreatic protein and proinsulin. So these are the antigenic, hence not used clinically. So these are the activates our immune system, hence not used clinically. Next comes to the human insulin. See, these are produced by rDNA technology by using the yeast. Okay, these have the amino acid sequence same as that of endogenous insulin, so having a less immunogenic, okay, less activation of immune system, insulin resistant lipodystrophy at the site of injection. At the site of injection, the lipid layer can be get destroyed, hence we can call it lipodystrophy. That is the human insulin that is produced from the rDNA technology. Next, last one is insulin analogs. Insulin analogs, these are produced by rDNA technology. Okay, the amino acid sequence is slightly get differs from the human insulin, but the actions are similar. Okay, only the pharmacokinetic profile is get changed. Only pharmacokinetic is get changed, but pharmacodynamic is constant in case of insulin analogs that can be synthesized by recombinant DNA technology. Next, when comes to the insulin analogs, modification only in B chain. Okay, we have discussed insulin containing A and B chain. Now we are doing modification only in the B chain. Okay, it may lead to the rapidly acting and onset of action in minutes. Okay, example is insulin lispro. See, this is the normal insulin. The B chain at 28 amino acid is proline, 29 amino acid is lysine. But what we have done modification in case of B chain, the 21 amino acid, okay, 21 and 28 can be exchanged. Just we have exchanged the amino acids, then 28 is lysine, 29 is proline. Next, insulin aspart. Okay, 28 proline is substituted by aspartic acid. See, 28 amino acid in human insulin is proline, that can be substituted by aspartic acid. Next, insulin glulicin. In case of this one, the third amino acid lysine, 29 amino acid also lysine. See, third amino acid lysine can be substituted by asparagine. 29 amino acid, that is lysine, are substituted by glutamic acid. Next comes to the insulin zinc combination. So onset of action is 1 hour, that is short acting, we can call it a short acting. Example is protamine zinc insulin, semilentin insulin, ultralentin insulin. So this is the zinc, it is can be surrounded by monomers. This can be surrounded by insulin monomers. See, AB nothing but heterodimer. So it is a heterodimer in low concentration solution at pH 7, it will forms the hexamer. Okay, what is that hexamer? I will discuss. The complex will alter the solubility. Okay, the complex will alter the release from the injection site. It will also alter the duration of action, alter the onset of action. So whatever this hexamer is there, that will alter the solubility, release, duration of action and onset of action. So these are the hexamers. See, insulin is a polypeptide hormone synthesized and stored in the granules in the beta cells of pancreas. Okay, human insulin for the injection is found in the form of hexamer. It was found in the form of hexamer. See, hexamer nothing but 1, 2, 3, 4, 5, 6. So it is hexamer. whereas insulin analogs are found as a monomers which diffuse rapidly. Okay, hexamers takes approximately 30 minutes to break down into the monomers in the subcutaneous tissue. See, this is a hexamer insulin. Okay, this is the black colored spot is there na? That is the zinc that is surrounded by insulin hexamer. So because of large size, this is the blood vessel. Because of this large size of insulin hexamer, it will be slowly entered into the blood vessel. So these are the endothelial gap. Okay, then what will happen after some time, insulin hexamer that can be converted into dimers. See, dimers 2 so dimers, it is having a see minimal diffusion. Insulin hexamer that is having minimal diffusion. When it comes to the insulin dimer, that is having limited diffusion. Okay, again this insulin dimers that can be converted into monomers after the 30 minutes. Okay, now this monomers having rapid diffusion. So like that we can increase the onset of action of this insulin analogs. Next, intermediate acting insulin, that is on 2 hours, onset of action is 2 hours. See, onset of action is 2 hours. Example is insulin, protamine, zinc. See, all these three components are in a stoichiometric ratio. This also we can call as a neutral protamine hexidone. Okay, neutral protamine hexidone, that is combination of insulin, protamine and zinc. Next, long acting insulin, that is onset of action is 4 hours. Insulin glargine, insulin dentimer. See the A chain. See, now we are doing modification in the A chain, substitution of 21 amino acid glycine. Okay, substitution of 21 amino acid by glycine. Next, in the B chain, addition of 2 extra amino acid, both arginines at the end of insulin B chain, lengthened to 32. So if it is a B chain, at this end we are adding 2 amino acids, 2 extra amino acid, that is arginine, along with 21 amino acid of A chain that can be substituted by glycine. So that is the insulin glargine. Next comes to the insulin dentimer. The terminal amino acid threonine are removed from the B chain 30th position, thus shortening the chain to the 29. So like this amino acid, 30 amino acids are there. If we have removed last one, then only 29 amino acids are there. See, the epsilon amino group of new terminal lysine at 29th position is covalently acylated with 14 carbon containing. See here, we need to substitute the myristic acid. 29th position, that is substituted with myristic acid, then we people will get the insulin dentimer. So this is about the insulin and insulin analogs that can be used in the type 1 diabetes. Next comes to the type 2 diabetes. In case of type 2 diabetes, we people need to use the drugs. What kind of drugs it is? Just observe here. Sulfonylureas, that is the first generation, that is 𝘾𝙀𝙍, that is a short acting drug. Okay, A nothing but acetohexamide, C nothing but chloropropamide, B nothing T nothing but 𝘾𝙀𝙍. Next, second generation, that is 4G, glibenclamide, glipizide, glucoside, glimepiride. So these are the second generation drugs. Next comes to the biguanides. Biguanides is fenformin. It is banned due to the lactic acidosis. Okay, metformin is there. It is causes lactic acidosis is less common lactic acidosis. Next comes to the miglutinide or phenylalanine analogs. That is metiglinide, repaglinide, natiglinide. Next, thiazolidinediones, that is thiaglitazone, pioglitazone, rosiglitazone, TPR. Next, glucosides inhibitors, that is acarbose and miglitol. Next, DPP4 inhibitors, that is sitagliptin and vidagliptin. So all these are the drugs can be used in type 2 diabetes. Can be used in type 2 diabetes. So new anti-diabetic drugs are there, that is pramlintide, exenatide, mazindol, cyclindol, mezindol, exenatide, pramlintide, pramlitinide drug. So these are the new anti-diabetic drugs. Okay. Next, next comes to the mechanism of action of sulfonylureas and meglitinides. Mechanism of action of sulfonylureas and meglitinides. So this is the cell that containing GLUT2 receptor. So these drugs, it will increases the sensitivity of cells. It contains GLUT2 receptor. Through this GLUT2 receptor, glucose can be entered into the cell. If glucose entered, that glucose can be enters into the Krebs cycle, then what will happen? ATP can be synthesized. Once this ATP can be synthesized, that will go and bound to the potassium channels. Okay, ATP that will go and bound to the potassium channels. Now what will happen is activation of potassium channels. Through this potassium channel, the potassium will go outside. The potassium, it will go outside. Then what will happen is negative charge, hyperpolarization will be there. So no insulin release will be there. Okay, but here ATP sensitive potassium channels, we can call it ATP sensitive potassium channel. But sulfonylureas along with meglitinides, that will inhibit the ATP sensitive potassium channel. So what will happen if the potassium channels are inhibited, potassium will not go outside, so it will stay inside. So potassium, that can be increased concentration of potassium leads to the increased positivity within the cells. So that will activate the voltage gated calcium channel. See, whatever this increased concentration of this potassium, that will activate the voltage gated calcium channel. Once this activation of voltage gated calcium channel, the calcium can be entered into the cell. So the calcium that can be entered into the cells. Once the calcium get entered into the cell, increased calcium level, so it is responsible for the release of insulin. It is responsible for the release of insulin, like that. Sorry, so it leads to the reduced level of insulin, not increased, reduced. It leads to the reduced level of insulin. Okay, when it comes to the adverse effect, hypoglycemia is a most common adverse effect, can be associated with sulfonylureas. Next, teratogenicity, it will cause a teratogenicity. A, nothing but allergic reactions. C, nothing but chloropropamide, it will cause disulfiram like actions. Next, teratogenicity. So sulfonylureas are not safe during pregnancy condition. Next, 4G, GIT disturbances like nausea, vomiting, diarrhea and flatulence. So weight gain will be there. It is due to the stimulation of appetite. Next, we can contraindicate sulfonylureas with salicylates or sulfonamides. Salicylates is NSAIDs. Sulfonamides is antibiotics. Okay, beta blocker drug. Sulfonylureas can be contraindicated with beta blocker, that is propranolol drug. Okay, sulfonylurea that may not be given with phenobarbital and rifampicin. Sulfonylureas may not be given with sulfonamide and warfarin. Next comes to the drugs, tolbutamide. So it is containing toluene. So it is containing toluene along with butyl group is there here. Okay, amide group is there, sulfonamide. Okay now. So this is a drug structure. See the numbering. First we need to identify the functional group. So sulfonamide amide group is there. Automatically sulfonamide group will get more priority. Then what will happen? Numbering will start with sulfonamide. Like that. The numbering is like this. So IUPAC name is benzene sulfonamide. So sulfonamide group is there on benzene. Hence benzene sulfonamide. 4-methyl. Fourth position it is containing methyl group. Okay. Nitrogen. See N position it is containing. What it contains? N, butyl amino carbonyl. See butyl nothing but this 4 carbon, amine this one, this group, keto group we can call as a carbonyl. So that is the tolbutamide. So this methyl group is there na, that methyl group that can be metabolized to CH2OH. So because of this metabolism it will undergoes OH group, it will undergoes glucuronide conjugation. So it can be immediately eliminated from the body. Eliminated from the body. So hence it is short acting drug. Next, chloropropamide drug. So chloropropamide drug that is containing chlorine, okay, propyl group, okay, sulfonamide. See the same functional groups are there, sulfonamide and amide. So numbering with sulfonamide only. See benzene sulfonamide is there. Okay. Next 4 position it is containing chlorine group. Okay. On N what is there? Propyl carbonyl. See propyl group is this amide group we can call as a carbomoyl. Carbonyl plus amine this nitrogen. Hence we can call it a carbomoyl group. So this chlorine is there. Chlorine is not metabolized immediately. Hence chloropropamide is a long acting drug compared to tolbutamide. Next tolajamide. It is containing toluene. Okay. Next aja nothing but nitrogen along with amide group. See numbering functional groups are same, so the numbering is remains same. So here benzene sulfonamide is there. Okay, fourth position it is containing methyl group, so 4-methyl. Okay, next one is on nitrogen. What is there? As nothing but nitrogen, EP nothing but 7-membered ring. Okay, 1-yle first position it is get substituted to sulfonamide, followed by amine group is there. Next carbonyl group. So this is the numbering and IUPAC name of tolajamide. Next acetohexamide. See acetyl group is there. This is a hexyl group. Next amide, sulfonamide. So same functional group. This is the numbering IUPAC name. See benzene sulfonamide is there. Okay. Fourth position it is containing acetyl group. Fourth position it is containing acetyl group. On nitrogen what is there? Cyclohexyl. Cyclohexyl. This one is cyclohexyl. Carbomoyl group is there. Then benzene sulfonamide. Next glibenclamide. Okay. Gly nothing but glycemic. Ben nothing but benzene. Cl nothing but chlorine sulfonamide. Okay. Benzene group is there. Okay, followed by chlorine is there, followed by sulfonamide. So here amide group is there. Okay, here sulfonamide group is there. So amide will get first priority here. So numbering started with amide containing group. Again numbering for the benzene. So here 2-methoxybenzoamide. So this structure we can call as a benzene. Second position it is containing methoxy group. Okay. 5-chloro. Fifth position it is containing chlorine group. Then at first position it is containing what it contains. The entire substituent is there. This. So on nitrogen what is there? On nitrogen 2,4-cyclohexyl. So cyclohexyl. Carbomyl group is here. Carbomyl group. Sulfomyl. This is a sulfomyl group. Next phenyl group is this one. Okay. Ethyl group is here. 2 carbon containing ethyl group. Okay. 2-methoxybenzoamide. So this is a IUPAC name of glibenclamide. Next comes to the glimepiride. So this is the structure of glimepiride. Okay. So the numbering is 1 to same as that of glibenclamide. Okay. So this is the structure is pyrrole 1-carboxamide. See one position it is containing. See its second and fifth position it is containing hydrogen, hence 2,5 dihydro 1H pyrrole. Okay, 1-carboxamide. So 1-carboxamide it is. Okay. 2-oxo. See second position it is containing keto group, hence we can call it 2-oxo group. Next it is attached to the ethyl group. It is attached to the 2 carbon containing ethyl group. Ethyl group that can be attached to the ethyl group that can be attached to the phenyl group. Okay, phenyl group that can be attached to the sulfomyl group. Okay, sulfomyl group that is can be attached to the carbomyl group. Carbomyl. Next carbomyl group that is trans 4-methyl cyclohexyl. So fourth position it is containing methyl cyclohexyl group is there. Okay. Third position it is containing ethyl group. Fourth position it is containing methyl group. So this is the IUPAC name of glimepiride. Next comes to the metformin. This is the structure of metformin. Okay. See pharmyl group. See one carbon containing NH. Oxygen is, see, oxygen isosteric replacement with NH. We can call as a formide group. Okay, hence formyl nothing but one carbon containing these groups. Okay, met nothing but methyl group is there. Methyl group. Formin nothing but formation of insulin or one carbon containing functional group along with amine. See here amine group is there. So this is the N, N dimethyl. Okay. So N, N dimethyl dicarbonimidic diamide. So dicarbonimidic diamide. So this is the IUPAC name of metformin. So the basic nucleus is guanidine. So the basic nucleus it is containing guanidine 1, guanidine 2. Hence we can call as a biguanide. Next miglitol. Okay, miglitol nothing but it is containing methyl group. Sorry, nothing but it contains amine group. Amine group is there. Gly nothing but glycemic, anti-hyperglycemic. Tol nothing but triol, 3 alcohol group is there. So this is the structure of miglitol. So when it comes to the structural activity relationship, the R position is lipophilic. Okay, that is in case of first generation. If first generation we have discussed first and second generation. First generation is stacked, second generation is 4G. In first generation R group is methyl, chlorine or acetyl group. Tolbutamide, chlorpropamide and acetohexamide. So it is a less lipophilic and more water soluble. Okay, in case of second generation, it is a bulky aromatic and heteroaromatic groups. So these are the more lipophilic, more potent. So second generation are containing in the R position, it contains bulky aromatic and heterocyclic groups. So these are the more lipophilic and more potent. Next comes to the sulfonyl group. Sulfonyl group SO2 group binds to the receptor. So hence act as a pharmacophore, followed by sulfonylurea. Okay, this is the sulfonyl group followed by urea group. See this sulfonylurea that will form a hydrogen bond with water, thereby increases the water solubility. So this is the urea group, NHCONH, urea. So up to here, sulfonyl with urea, it will forms hydrogen bond with water, thereby increases the water solubility. Next comes to the R1 position, this is a lipophilic. In case of second generation, it is bulky aromatic, heteroaromatic, more lipophilic, more potent the drugs. So this is the structural activity relationship of sulfonylureas. Okay, sulfonamides. Okay, these are the antibacterials, also have the oral hypoglycemic effect due to sulfonamide group. See, this sulfonamide group also located in the sulfonamide drugs, that is antibiotic drugs. So sulfonamides also has the chance of oral hypoglycemic property. So meglitinides, this having rapid onset of action but short duration of action. Hence used only in type 2 diabetes mellitus to control the postprandial after the food hyperglycemia. Contraindication should be avoided in hepatic failure patient. Side effect is weight gain. So mechanism of action of meglitinide they have asked in the GPAT 2016. Okay, next comes to the biguanides, fenformin, metformin. Okay, it will come and bound to the AMP dependent protein kinase receptor. Simply we can call as a AMPK receptor. So by binding to this receptor, it will has the chance of or the actions of inhibition of gluconeogenesis and inhibition of elementary absorption of glucose, thereby reduce the glucose level in the blood. Along with it will increases the stimulates the peripheral utilization of glucose. So that is the mechanism of action of biguanides. See adverse effects of biguanides. Biguanides, it will causes lactic acid acidosis due to the fenformin. See lactic acidosis that can be caused by fenformin, hence fenformin can be banned. Next, megaloblastic anemia due to vitamin B12 deficiency caused by metformin. So this is a guanide. So this is a biguanide. Okay, it contains nitrogen, it contains lone pair of electrons. It will forms hydrogen bond with hydrogen atom of water. Okay, like this 5 hydrogen bond donors, 7 hydrogen bond acceptors. So because of this, it is a highly water soluble. Biguanides are highly water soluble due to amine functional group. Okay, highly basic due to the presence of more number of nitrogen atom. So present as a ionized form. So these are always ionized form in the body, hence eliminated by active tubular secretion. Absorption is by paracellular route. Next comes to the thiazolidinediones. So they increase the sensitivity of peripheral tissues to the insulin. So pioglitazone, rosiglitazone, it will bound to the nuclear PPAR gamma, nothing but peroxisome proliferator activated receptor. Okay, activate the insulin responsive gene that regulate the carbohydrate and lipid metabolism. Finally, it will causes sensitizes the peripheral tissues to the insulin. See, thereby it reduces the blood glucose level by increasing the glucose transport into the muscle and adipose tissue. Inhibit the hepatic gluconeogenesis, promoting the lipogenesis. So by this mechanism, thiazolidinediones that can be increase the sensitivity of peripheral tissues. Next comes to the alpha glucosidase inhibitor. See, polyditrisaccharides, okay, that can be converted into monosaccharide in the GIT tract with the help of alpha glucosides. So if you are inhibiting these drugs, what will happen, sir? No conversion of saccharides, polyditrisaccharides into monosaccharides. So unabsorbed carbohydrate fermented by intestinal means this can be remain in the intestine only. This can be remain in the intestine. So if it is there in the intestine, what will happen? Some of the bacteria that will act on these carbohydrates thereby releases the carbon dioxide gas. Okay, the drugs are alpha glucosidase inhibitor, acarbose, miglitol and oglibose. So this drug should be taken before the food, and these drugs majorly used in the obese patient with type 2 diabetes. Next, incretins. See, incretins are oral glucose provokes 4 times greater than insulin release than intravenous glucose. See, this is because oral glucose releases the GLP, glucagon like peptide 1, that will amplifies the glucose induced insulin release. GLP secretion is reduced in patients with type 2 diabetes. Okay, see, incretins like GLP-1 has the little stimulatory effect on insulin secretion at normoglycemic concentration. Okay, this GLP has lower risk of causing hypoglycemia apart from releasing insulin. So GLP-1 has the following actions. One is suppress the glucagon release. Okay, preserves islet cells integrity and decrease the apoptosis, followed by delays gastric emptying resulting in a reduced appetite. So these are the actions, different actions of glucagon like peptide. So endogenous GLP is rapidly metabolized by the DPP4 enzyme. Okay, dipeptidyl peptidase 4 enzyme, thus having short duration of action, that is 1 to 2 minutes. Okay, so the two strategies by which incretin effect can be strengthened. One is GLP-1 receptor agonist, that is exenatide liraglutide, exenatide liraglutide. So these are the two drugs. Okay, these are the GLP-1 receptor agonists. This can be administered by subcutaneous route. The mechanism of action is similar as that of GLP-1. Okay, new drug of this category is 𝘖𝐵glutide, dulaglutide. So new drugs that will comes under GLP-1 receptor agonist. So DPP4 inhibitors. See, DPP4 enzyme, what it will do means it will increase the incretins, GLP and GIP. It will, see, this incretin stimulates the insulin release but inhibit the insulin. It will stimulate the insulin release but inhibit the glucagon release. Inhibit the glucagon release, thereby reduces the blood glucose level. Okay, incretin, GLP nothing but gastric inhibitory peptide. Okay, GIP nothing but glucagon like peptide. Here not insulin, here glucagon. So if we have inhibited this DPP4 enzyme, then what will happen is no synthesis of GLP and GIP. So what? No reduction of blood glucose level. So no reduction of blood glucose level will be there. Okay, see, this endogenous GLP is rapidly broken by DPP enzyme, so we need to inhibit that DPP4 enzyme. Next, sodium glucose cotransporter. So this is the renal tubule. Okay, this is the blood vessel. In between this, what is there? SGLT2, sodium glucose cotransporter 2. Okay, see, by that what will happen is the glucose that can be entered into the blood vessel. if we have inhibited this one, the glucose may not be entered into the blood vessel, then it can be excreted through the urine, so thereby we can reduce the glucose level in our body. So this is the mechanism of action of sodium glucose cotransporter, that is dapagliflozin canagliflozin, dapagliflozin, canagliflozin. So these are the drug act by inhibiting sodium glucose cotransporters. Next one is amylin analogs will be there. So this will act by decreasing the glucagon secretion, delaying gastric emptying, decrease the appetite. Okay, decrease the appetite about the. Next, it is administered by subcutaneous route, so it can cause weight loss. It is approved for the treatment of type 2 diabetes, along with bile acids binding regions also there, that is also can be used in diabetic condition. So with this we have completed the topic of insulin and oral hypoglycemics.